A warm good evening, everyone. Thank you so much for joining in. It's a wonderful Sunday again. We're back with the second episode of the International E-CONCLAVE on oral cancer. Today, this year's theme is capacity building for oral cancer. And now we move ahead to our scientific sessions. We're going to have.
Thank you very much. To begin the scientific sessions, the first scientific session is on oral lesions and understanding osseous invasions and choosing the optimal imaging tool to actually diagnose the osseous invasions. And the chairperson for this session is Dr. Manish Munjal. He's a senior consultant in ENT at Sir Gangaram Hospitals. In the same breath, I would also like to invite the speaker for this session, Dr. Vishal Dang. He's a very decorated speaker. He's a visiting professor at the University of Detroit School of Dentistry at Michigan, USA. Extensive teaching experience, about 24 years of experience, and that's why he has been invited to enlighten us on this topic. And he has been an MDS examiner and also has published numerous books, and he's the past president of IAOMR.
Without much ado, I will start with my presentation. At the outset, I must thank the organizers, Shruti, who I've just heard now, and she's been in touch on the email, Dr. Reena, who's a very dear friend, and Dr. Pavan Gupta, the force behind ICanCaRe, whom I've known for several years, but we don't meet often, but I know how passionate he is about tobacco cessation and, education. So also a big thanks to the Gujarat University and the Head and Neck Oncology Foundation, serving hospitals to bring this event together. So I'm the opening batsman, I presume, and Dr. Munjali, the chairperson, and Dr. Saha, thank you so much for your introductions. So as an opening batsman, I'm not really worried about the ball which I'm going to face, because the scourge of oral cancer hits me right in the face. I know what we are facing and how to sort of, how to manage this disease is a big challenge. So my presentation is actually confined to understanding something about how invasion occurs in cancer, but more importantly, how to choose the tool for imaging. Unfortunately, we don't have very clear-cut protocols which are sort of accessible to all the practitioners as to how imaging should be done when we talk about diagnosing a suspected case of oral cancer. So before I start with the topic sort of per se, we have talked about capacity building, which is the theme of this event. Now, as a dental surgeon, my presentation is sort of focused from the dentist's viewpoint, because I think we are at a very advantaged position, and we can do much more than what we are doing. And it's our job to see that the younger people entering the profession, their training and their subsequent practice helps us to control oral cancer as a part of a big multidisciplinary approach. I mean, we are part of a big team of healthcare workers. We must understand the importance of our role in this big ocean, if I may call it. We have a huge number of dental colleges, a huge number of registered dentists. It is the highest in the world, Today, we have the highest number of registered dentists, almost touching about 3 lakhs. We have a huge number of graduates coming out each year, and even our dentist to population ratio today is not too bad. But the problem is that we don't have the dentists at the right places. We have them, confined to the metros and not in the areas where perhaps they can make a bigger difference. Now, can we do more than what we are doing? As Dr. Reena mentioned, that we have approximately 77,000 new cases of oral cancer being diagnosed each year. When I say oral cancer, I'm talking of oropharynx and oral cavity proper. So I'm not talking about the other surrounding areas. And we have over 50,000 deaths per year on account of oral cancer. So there's a huge opportunity and there's a huge challenge, for a dental surgeon. Now, the opportunity is that as was just mentioned, that we can actually see the mouth of every patient that we are examining for dental work. We are also critical not just in dental disease identification, but we are also a very important, force which can be used for tobacco cessation activities. We are also a very important group of doctors who may contribute to upkeep of oral health of the patient prior to treatment for oral cancer, during treatment, and post-active treatment of oral cancer. And of course, subsequent surveillance, which is required to identify recurrence, also can be perhaps best performed by a dentist who calls his patients every 6 months for a checkup. So we have a very strategic role to say, so as to say, in this entire process, right from prevention to early diagnosis to pre-treatment planning of dental care, ongoing treatment care for the mouth, and post-cancer management care, rehabilitation, and a surveillance for recurrence. But there are some challenges. I've been teaching for so many years, and I find that when a student joins dentistry, he is somehow, geared up, he's programmed to just see the teeth and how he can work on the teeth, give relief to his patients, and earn his bread and butter. But we, as oral medicine specialists or oral physicians, we must train our students to examine the entire oral cavity and not just confine to a patient's complaint when he visits us. We can motivate the patients, and we need to do more in this regard in tobacco cessation. Now, why is it that dentists perhaps don't identify as many cases of oral PMDs and early cancer as they should? I think that some sort of incentivization is also required in a larger way for the normal dental surgeon as to why should he go into this area of cancer prevention, tobacco cessation, early diagnosis, and very importantly, that even today I find that there's a lot of confusion in the minds of the dentist as to what are the guidelines and the protocols for referral. What should he do when he suspects, a patient to have a potentially malignant disorder? We get referrals, but somehow there's a fear, psychosis, there's a bit of, clarity missing, if I may say so. And when a patient is referred by a dentist to an oncology center, there must be a system of a reverse feedback for the dentist so that he can, at the end of the day, have that satisfaction that performed a small part in this big jigsaw of oral cancer. Now, as we know that oral cancer could be an exophytic or endophytic growth. In fact, the ICanCaRe, brochures, they talk about a chota dana as the first sign of oral cancer. I was just wondering, is that chota dana enough? I would say it could be a ghav, it could be a dhabba, or it could be a dana. So, it could be an ulcer, or it could just be a patch, or it could be a dana. And anything could represent something which is as, harmful as a malignant disease in the mouth. So these are just some pictures. I am just going to move fast to save on time and coming to the main area. We do have situations like this where a white patch, now if this sort of a patient reports to a private dentist, perhaps the dentist is not sure what he's seeing, and so he must be clear in his mind that what is the protocol of examination, of history taking, and also of referral if he suspects oral cancer. Now, oral cancer is not just squamous cell carcinoma. We also have other varieties of cancer, and this patient was one who presented with low-grade osteosarcoma. So when you talk about diagnosing oral cancer, at somewhere at the back of our mind, we also need to keep other cancers in mind, which can be seen in the mouth. Now, when we talk about oral cancer and bone invasion, see, invasion or spread of cancer can be a direct extension to the neighboring structures, or it could be an erosive or an infiltrative entry into the bone. And this part, bone involvement, is important because it has both therapeutic and a prognostic importance. So when we talk about jaw bone involvement, it is usually the gingival carcinoma which is in direct contact with the alveolar process and often is not diagnosed early enough. The problem with oral cancer is the poor survival rate of under 50% is on account of the fact that diagnosis does not happen in the early stage. Unlike breast cancer and even cervical cancer, where I think the medical profession has succeeded more, but in oral cancer, sometimes there may be confusion. There may be a confusion vis-a-vis the differential diagnosis. It could, somebody might think it's a periodontal disease or pyogenic granuloma. It's just some other white lesion which may not be cancer or a potentially malignant disorder. So sometimes the diagnosis gets pushed by not just a few days but by weeks and months, which may be quite critical to the outcome of disease for that particular patient. So what is, after all, the aim of imaging in oral cancer? The aim of imaging is primarily it is for staging of the tumor. And we have to stage the tumor, we have to do a node staging and also understand if there are any distant metastasis. And even subsequently, for follow-up, after the treatment has been completed, we need to have some studies which can be compared with the pre-treatment, images. And so the question arises, what should be the optimal imaging tool, which was the gist of the topic proposed to me. Now, you can't answer this question in a very simple black or white way. The optimal imaging tool would depend on many factors, and a tool is only as good as the doctor who's using that tool. So if this tool is in the hands of a dental professional, then it would be probably different from the approach taken by a oncology center, where if a patient goes direct to the oncology center, the imaging proposed would be with a different protocol. But I'm trying to bring the two streams together, and I'll propose what I think is the right way of proceeding. So for primary tumor assessment, if you are talking about oral cavity and other supra-higher tumors, I would say, as a dental surgeon, because taking care of the mouth and the teeth is anyway very important, because the teeth have to be treated, the gums have to be treated before you can start cancer treatment. So panoramic radiography and intraoral radiographs are very important tools for screening initially. And they are easily, available. The cost is not much. And we also have now something called cone beam CT. So a dental surgeon is somehow more comfortable with these tools of imaging as compared to, say, a CECT or an MRI. But still, having said so, the thumb rule still remains that the soft tissue extent of disease is perhaps best identified or understood with an MRI. Although a contrast enhanced CT may also sometimes be used, especially if you're looking at the chest subsequently. So you might want to just do a CECT instead of straight away jumping to an MRI. But MRI, of course, is the gold standard for soft tissue extent of oral cancer, whether it is of the tongue or any other soft tissue site in the mouth. But when it comes to bone involvement or invasion, then there is a bit of a dilemma, or we have to decide what would be the optimal tool. Now, this is just a simple panoramic X-ray. Now, it could give a lot of information, but again, interpreting panoramic radiographs, this is a practice which is not followed across the country. Panoramic radiographs are not, interpreted and reported by all the centers, and so we don't get all the information which one can obtain from these radiographs. Whereas if you're doing a contrast-based sort of CT study, you can study the soft tissue in a soft tissue window, you can study the bone in a bone window, and you can understand the extent of disease, the invasion of the bone. And invasion of the bone is important because if the bone invasion is confined to, say, the cortex or it's just an erosion of the cortex, such a tumor cannot be classified as a T4 lesion. So, for example, if there's a extraction site and a superficial erosion is seen at the extraction site of suspected cancer, we can't put it as a T4. For T4 involvement, there has to be some invasion into the spongiosa, into the medullary bone. And the moment the tumor goes into the spongiosa, then the prognosis, the survival rates are affected, adversely. So it is important to catch the disease before it reaches that T4 stage, before that bony invasion. And if we are talking about the maxilla, the antrum, for example, the sinus, if it has to be studied for invasion, then right in the beginning itself, we can choose a CECT to say a CBCT or an MRI, because bone involvement is better understood using the CT images. But a CBCT is also very effective sometimes and can be used especially in the dental scenario, because dentists somehow seem to be more comfortable with CBCTs since they are using them more often. Now, if you're not seeing any change in the CT or the CBCT, and you want to pick up a very small change in metabolism of the cortical bone, then a radioactive isotope scan or a SPECT scan may be useful. And this is also in the absence of a primary. If you don't see a primary on your MRI or CT, then perhaps you need to do a PET CT scan and try to identify the primary. You may have a case where there is suspected metastasis in the cervical nodes, but you can't see the primary in the mouth. So in these cases, you may need to do a PET scan to identify the primary. So when you are doing a radioactive isotope scan, it is important to remember that gum disease, periodontal disease can also indicate certain areas of increased, radioactive isotope uptake, which must be kept in mind when we analyze these radioactive isotope scans. For node assessment, I would say that the CT, MRI, and even the ultrasound are good modalities of imaging. It all depends on in whose hand that particular tool is. An ultrasound is good because it's very fast, it's very easily accessible, and it is quite cheap. So all these advantages are there, and it can sometimes give information as good as a CT or an MRI. In fact, 20% of occult nodes which are not examined clinically, will show nodal metastasis on some form of imaging. This sort of statistics is very important and must be kept in mind when we examine the patient clinically. And of course, I just forgot to mention that when you're talking about nodes, for metastatic nodes, it is the size of the node, the minimal axial diameter of the node, even more than the structure and surrounding infiltration, which is considered to be sort of the gold standard. If it is more than 10 millimeters in size across the minimal axial diameter, except for junctional nodes where it's 15 mm, in these cases, we would consider a nodal metastasis to be positive. And if we are wanting to rule out metastasis to the chest, for example, if it's a T1 disease, we don't even need to do a CT scan. The accepted sort of norm is that an X-ray chest may suffice to rule out metastasis, a normal X-ray chest, APU of the chest. Whereas if we are staging it as T2, then we may need to do a CT scan to rule out metastasis. And also sometimes you find a second synchronous malignancy, you might find a bronchogenic carcinoma in addition to what you're seeing in the mouth. So follow-up imaging I'm just about to finish, another minute or so more. So when we follow up imaging to sort of exclude recurrence of disease, this protocol should be that the method used should be the same as what was used before, because comparison is very important for understanding how recurrence may or may not have occurred, and this is best performed about 2 to 4 months after the active treatment, not before 2 months anyway. So in summary, I would first say that in a dental setting, say a teaching institution or a big dental hospital setting, intraoral radiographs, panoramic radiographs, and CBCT may be the good methods of identifying involvement of bone, and these could be complemented by a subsequent MRI for soft tissue extension of disease, including assessment of the nodes. This is in the dental setting. However, if the patient has gone straight to the oncology hospital or to a cancer center, I think that perhaps the onco surgeons or the medical oncologists or the radiation oncologists, they will perhaps prefer the use of a CECT and MRI, or one or both of these, to move further in management of that particular patient in treatment planning. And ultrasound, as I said, is extremely useful. It can also be used for a fine needle aspiration cytology, but it all depends on the competence of the operator. And scintigraphy, as I mentioned earlier, are useful in detection of initial involvement of the bone, and when nothing is seen anywhere, or sometimes even when you're doing a follow-up, a PET CT scan is sometimes indicated. And so again, to emphasize that, we must have a clear-cut protocol of imaging in all cases, and we must have the same modality to follow up the patient subsequently that which was used in the beginning of treatment. So as I would just always emphasize to my students that tobacco cessation is so well performed by dental surgeons, and in fact now the Dental Council of India has made it mandatory that all dental colleges should have a tobacco cessation unit in the college, where a specialist from the Department of Oral Medicine, which is the specialty which I represent, or oral pathology is in charge, and we actually are responsible for counseling of the patients and making sure that, tobacco cessation is very nice when you talk about it, but at the same time, the failure of converting a tobacco user to a non-tobacco user, that failure rate is very, very high, So even if you succeed in converting one tobacco user out of 5 into a non-tobacco user, I think you've done a good job. So that's at least a beginning. And as dental surgeons, we must pledge to make a bigger and a better impact to minimize the impact of oral cancer in India. Thank you for this time and patient hearing. Thank you so much.
Thank you very much, Dr. Dang. That was an excellent, informative opening session by you. And you definitely underscored the huge opportunity of the entire dental faculty for early diagnosis of the head and neck cancers. And you have seamlessly kind of highlighted the spectrum of investigations which are required, which are actually carried out right from the intraoral radiography and cone beam CT to the more advanced investigations which we are using, like CCT and MRI and PET scans. So an excellent presentation indeed, sir.